Good day. Welcome to part 2 of your common ophthalmologic ER cases. The following are considered urgent cases: acute angle closure, a recent onset strabismus, and optic disc edema. The patient comes to you complaining of sudden severe eye pain, blurry vision with a perception of halos around lights, associated with headache, nausea, and vomiting. Next, you do your ophthalmologic examination. On gross examination, you note the following: conjunctival injection, the pupil is mid-dilated and is non-reactive to light. You also note microcystic corneal edema, which is like the cornea having microbubbles. On palpation tonometry, you note that the eyeball is firm to hard. Confirmatory exams, such as the Goldman applanation tonometry, confirms that the intraocular pressure is increased. Gonioscopy, which is done to visualize the angles, confirms the presence of angle closure. Remember, aqueous fluid is produced by your ciliary body, flows through the pupil and onto the anterior chamber. To maintain a normal intraocular pressure, excess aqueous fluid is drained by your trabecular meshwork. The trabecular meshwork is found in the angle of the eye, which is formed by the cornea and the iris. In primary angle closure, the posterior surface of the iris adheres onto the anterior surface of the lens. Because of this, aqueous builds up behind the iris, pushing the iris forward and thus closing the iridocorneal angle. The primary management of angle closure is aimed at reducing intraocular pressure. The following drugs may be given to quickly suppress the production of aqueous humor. Of course, the definitive management of angle closure is through laser or incisional surgery in order to relieve the pupillary block.
With laser iridotomy, the ophthalmologist uses a focused beam of light to create a tiny opening about the size of a pinhead in the iris. This opening allows trapped fluid behind the iris to flow into the front of the eye, usually reducing pressure. A laser iridotomy is an important way to treat or prevent a sudden rise in eye pressure that can seriously affect your eyesight.
The most common presenting symptom of a third nerve palsy is binocular diplopia. Remember that the third nerve innervates most of the extraocular muscles, with the exception of the lateral rectus and the superior oblique. In a third nerve palsy, the eye assumes a down and out position. This is because the lateral rectus and the superior oblique are unopposed. Since the third nerve also innervates the levator palpebrae superioris, some patients may also present with ptosis. It is very important to check for pupillary involvement. Most cases of third nerve palsies will require workup. This is to rule out fatal causes such as a ruptured aneurysm. Again, please take note of the down and out configuration of the globe as well as ptosis in this particular patient. The lateral rectus is innervated by the sixth nerve. Paralysis of cranial nerve number 6 will also present with diplopia. In this condition, the eye assumes an inwardly rotated position. Optic neuritis is the inflammation of the optic nerve. Most patients present with the unilateral progressive blurring over the course of a few days. Minimal pain may accompany eye movement. Patients with optic neuritis are usually females belonging to the 18 to 45 age group. The picture on the left shows a swollen optic disc, while the picture on the right shows a normal looking optic disc. It is very important to note that majority of patients with optic neuritis will present with a normal looking optic disc. Workup is often mandatory as there is a strong correlation of optic neuritis with multiple sclerosis. The recommended treatment of optic neuritis starts with a 3-day dose of IV steroids. This is then followed by an oral dose to complete a treatment duration of 14 days. It is important to note that optic neuritis usually presents with the unilateral optic disc swelling. The finding of a bilateral optic disc swelling should raise a suspicion of an increase in the intracranial pressure.